So as I mentioned before, there's three categories. So there's temporal plus onset. There's, to address this, there's an inadequate resection, which can happen sometimes in other centers, and we see that not infrequently. And then there's something called pre-surgical false lateralization, and we'll talk a little bit about each of those. So what we know, first of all, is we'll talk about temporal plus onset. So when we say temporal plus, what we're saying is that the temporal lobe is involved with the seizures, but there's this plus element. It's either the orbitofrontal cortex, the insula, the cingulate. There's another area that's equally causing epilepsy. And what we know is that if you have a patient who has temporal plus another area, if you do a simple temporal lobectomy, they're very, very likely to continue having seizures. And so one of the things you have to be very careful of is that you sample all the areas that you think the seizures may be coming from, because you're only going to get data from the areas that you sample. So if I look at a patient and I implant them only in the temporal lobe, well, if they have something from the orbitofrontal, for instance, we are going to miss that because we haven't looked in that area. And we may be falsely, comforted and say, oh, well, it has to be from the temporal lobe. And so it's very important to keep this in mind as one of our, treatments for these types of patients. This is another very common problem that we see, which is an inadequate resection. And patients have come to us at UCI from all over. And unfortunately, they may have had surgery done somewhere else. And, the surgeon tells them at the end, well, this is, we did a complete resection, everything's clean. And they may come to us and say, looking for answers, and we may be able to find an area that was not removed. And in those patients, that's kind of my favorite type of patient because it's a simple procedure we can do. We call it a cleanup surgery, and oftentimes those patients can become seizure-free. And so it's very important as well to be very mindful of that. And every time I do a resection, I'm very careful to remove every little bit of tissue that may be causing seizures. When you do that, then if they come back, and it's unfortunate, and if they come back with epilepsy, we know that at least there's not a residual component that we just seem to have missed. And then the last part is false or incorrect lateralization. And this is a very, very difficult one. This is one that we worry about all the time. And what I mean by this is that you may, as I mentioned before, let's say we did all our testing and we see the right temporal lobe is where we think seizures are coming from. And let's say we implant on the right temporal frontal, we do a very nice right-sided implantation, but we don't look at the left side at all. Well, oftentimes what can happen is that you can have seizures start in one side, let's say the left side, and then very quickly move to the right side. And even in that type of a patient, you may implant the right side only and say, oh, I see all these seizures are coming from there. But unless you're careful and you look at that left side, you're going to completely miss that. And we know that those patients have very poor outcomes. And in fact, you're removing the normal area or the temporal lobe that's not affected, which obviously is really kind of the worst case scenario. So, how do we mitigate these risks? As I mentioned before, when we come up with our preoperative plan, we're very careful to implant all the areas where we think seizures may be coming from. This is probably the best way to minimize that. Now, at the same time, we don't want to implant unnecessarily. We don't want to put electrodes in where we could, we may just, it's not a fishing expedition. But what we're looking for are areas of the brain that may not necessarily, we may not be considering, but if they are causing seizures, we have to address those as well as the temporal lobe to really increase our chances of becoming seizure-free. So you see here again, just like I mentioned, we've sampled all the areas where temporal plus epilepsy can come from. We sample both temporal lobes to be safe. This is one way that we avoid incomplete resections. We do functional mapping. So these are all grids that are on the surface of the brain. And then, we've done a lot of very exciting and interesting work where we combine resections and RNS, for instance. So we can resect as much as we safely can. And then parts of the brain that we're not able to safely resect, we'll put a neurostimulation device there. And then that way we get the best of both worlds. We can resect it and give us the best chance of seizure freedom. But if there's an area we can't remove, we can still treat that with the neurostimulation device. And so we looked at our own outcomes, and we've seen that we've had very good results basically since 2015. With that same category of patient, you can see that our group of patients, we had about 67% angle class 1, which is the basically seizure-free group. And what that tells me, what we did there was we focused on those very difficult to treat patients, and really were able to get some of the best results, much better than what you see in the literature. And so I think doing the things that I've talked about today, some of the things that we do to really focus on and try and help those patients with MRI-negative epilepsy, we've been able to get very good results and get really that kind of that gold standard that we're hoping for.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.